Thank you for being here today with us and starting the Health Data for a Global Hybrid Summit 2025 edition this year in Wales. It's really great for me. I'm Paul Nunes Dia. I'm a certified professional facilitator from the IAF. And as a creator of spaces for dialogue, I have to thank everyone that made possible this event, in particular our main sponsors, because they are the creators of this dialogue, the spaces of dialogue we're going to offer you in these next coming days. This session already started yesterday with a deep dive. We are already creating a draft of a joint charter on the use of secondary health data that we hope collectively to accomplish something of significance on Friday and going forward. As it's normal here, the opening session will be done by our advisory board chair, Dr. George Mathew, and also the president of the Mathew Foundation, our patrons. And unfortunately, George cannot be here, but he recorded a video, which I hope you enjoy. And after this video, I'll take the floor to introduce our keynote speaker this morning. Thank you.
Borada, Croeso, welcome to the Health Data Global Hybrid Summit 2025 in Wales. George Mathew Dewey. My name is Dr. George Mathew. I'm the chair of the Health Data Forum and happy to be kicking us off. My colleague, Paul, will be introducing our first speaker, but I did want to express my thanks to all of you for taking your time and sharing your expertise. Ultimately, as we go forward and examine what we want to review over the next 2 days, keep in mind that our goal is to help each other learn. Each of us brings our own experiences, and each of us has something to learn from the other. And I thank you for sharing your experiences with us. From all of us to all of you, diolch. Thank you.
So it's now my pleasure to introduce Dr. Helen Thomas, who has led Digital Healthcare in Wales as CEO since 2021, guiding an impactful response to COVID pandemic and driving a rapid adoption of data and digital advancements across NHS Wales. She also oversaw DHCW's successful transition to a special health authority in April 2021, ensuring the continued delivery of essential national digital and data services. With over 30 years in the NHS, Helen began finance before moving into health information in 2000. Over 2 decades, she has held various senior informatic roles, spearheading digital transformation for more effective and safer care. Recognized as Digital NHS CEO of the Year in 2021, Helen holds MSc in Health Informatics and is a leading figure in her field, including being a professor of practice beyond digital delivery. She's passionate about fostering an inclusive organization, and it's a distinguished role model. Thank you very much, Helen, for being here. A round of applause.
Rhodri, Croeso. Really is a great pleasure to be here today, and thank you, Paul, for that lovely introduction. 35 years now, actually, so that's it's been a little while that I've spent in the health service in Wales. 25 of those years in what we used to call health informatics. I still can't let go of that title, actually, for me. So I'm a proud health informatician who happens now to lead in digital health for Wales. So I've got a couple of slides just to kind of introduce the topics and just to kind of set the scene for what our health data. That's a good start. There we go. Yeah, great. Okay. Just to set the scene really for the digital health data strategy is for Wales. So who are we? So I have the pleasure and privilege of being the Chief Exec for Digital Health and Care Wales. We are a special health authority, so we are a member of the NHS Wales family. We've been in existence for the last 4.5 years, actually. It's our anniversary coming up. We operate in a kind of partner as part of the NHS Wales family, along with the health boards and the NHS Wales trusts. I just need to know that there's a little delay. So a little bit about Wales, actually. I thought it would be helpful for colleagues who's their first visit, and hopefully you'll realise how beautiful the city of Cardiff is and the country is. But we're a small nation, small but mighty, maybe. Strong links between organisations in NHS Wales. So we kind of make progress through those strong relationships and strong links. So we've got a population of just over 3 million, 7 health boards that are responsible for the population health of their resident population. So they do the provision of healthcare services and they commission healthcare services for their population. We have 3 national trusts for public health, for ambulance and for cancer services and Welsh Blood. And then we have 2 special health authorities that are focused on arguably 2 of the most challenging and important areas of the health and care system, which is workforce and digital. But we've got some challenges. So I think, being a small nation, we have some opportunities, but we've also got some of our challenges, which are, these are not unique to Wales. We've got some global challenges that are facing the health and care sector right across the board. We've got recruitment and retention challenges. We all know that. So, there's almost a workforce crisis, isn't there, in terms of that challenge. We've also in Wales got the legacy of our post-industrial past. So really high levels of deprivation in some areas of the country and very high levels of comorbidities amongst our population, with about 2/3 of over 65s living with more than one chronic condition. That coupled with some of the geographic challenges that we've got in Wales. So we've got some high densely populated areas of Wales. We've also got some vast areas of beautiful countryside and rurality that we need to work through. We've got there's a bit of a north-south kind of difference, because we've got quite a lot of rurality up in North Wales, and then we've probably got quite a congestion so that's one health board that covers the whole of the north of Wales, as you can see. And then we've got kind of the cluster along the M4 corridor, which is in South Wales. In terms of the policy context, so we're very aware of that, but actually in Wales we've been kind of I would suggest world leading in some of the policy ambition and drive that we've got in Wales, and I think that's really helpful when you look at that in terms of the digital health context, so that we're clear about wanting to achieve a healthier Wales. That is our current policy for the health and care sector in Wales. And I'll talk a little bit more about that on my next slide. That's underpinned by our Wellbeing of Future Generations Act, which is really setting out those sustainability goals and what the nation that we want for our children and our children's children. So that's at the heart, really, of kind of the policy development and the decision making in Wales. That is also underpinned by prudent healthcare principles, and I'll talk a little bit more about that. So Healthier Wales will focus, and none of this is going to be unique, but this is our take on it, and this was our policy from 2018. The actions have just been recently refreshed by Welsh Government because the strategy still stands. We are wanting to focus on well-being and actually shift from being the looking after me when I'm sick to actually keeping me well service, and that we ensure that we have that level of integration across the health and social care sector, and actually our colleagues who do a tremendous amount of health and care work out in the third sector. So that ambition to deliver that shift left, that's right, isn't it? Shift left, to achieve that model of care closer to home, to really put the patient at the heart of it. And I wanted to touch on really the prudent healthcare principles. and I think they've been picked up in other countries now in terms of, at the time, so I think these would have been 2016, 2017, around that. Helen's at the back. Was it 2016? Was it Helen? So at the heart of everything that we should and try to do is that we co-produce. So a founding principle really is that we co-produce health and care in Wales with patients, with public, with professionals, that we work together, that we prioritise that need and that we treat those in the greatest need first. We reduce the variation and ensure that all of the interventions that we take forward are evidence-based, and that we have our colleagues, our clinical colleagues, actually work at the top of their licence. And one of the mantras is only do what only you can do, really, and that was right at the heart of prudent healthcare, and reduce those unnecessary interventions. So only do what is needed, do no harm. And actually I really like the simplicity of the message that we get from prudent healthcare. And part of my kind of reflections on this is you can't achieve prudent healthcare without data. And you don't have data without digital systems. And, you know, digital systems are there to support the health and care process and help us to understand it. So actually, when you look at what a data-driven system looks like, it is about ensuring, like some colleagues here from my organisation who've done some brilliant work in this space, but it is about really bringing to life the understanding of health and care at a person level and at a system level, and really understanding and transparently using that data in a safe and ethical way so that we can reduce harm, we can reduce variation, and we can actually target those areas of greatest need first. So what are we doing within Digital Health and Care Wales, or actually as a system with our partners, to bring this to life from a digital and data perspective? So the bit about putting the patient at the heart, so the patient is empowered to take care of their own health and well-being, are empowered to co-produce and co-participate in their health and care journey. So the NHS Wales app is central to that strategy for us, and that is ever expanding now with around 500,000 users of the app now, and we expect to see that rise quite significantly over coming months and years with the more functionality that is added to it. But we've also been looking at that reducing harm focus. So digital medicines is a huge strategic focus for us in Wales, both in hospital and out of hospital, but actually not just about the functions of being able to prescribe and dispense services. This is about actually having at the core of our architecture that medicines record. And we all know there is such a rich kind of seam of data when you get into kind of the medication record. So having that as a central kind of tenet of the architecture at a person level actually opens up so many avenues for us in terms of the data and analytics that we can undertake. A huge focus on diagnostics and the streamlining the digital offer across primary and community care services. All of that really, again, you can't do without data, and actually having data in the way that you can access it and use it in a way that as a health informatician I've probably completely de-skilled now, wouldn't be able to do it in the way that I used to enjoy doing. But having the National Data Resource as another of our foundational, and you're going to hear a bit more about that today, our foundational programmes to actually provide the platform and the capabilities, both in terms of technical capabilities and the people, the skills capabilities, is kind of key to our strategic approach. It's a little bit slow. So I'm not going to spend too much time on this, but the National Data Resource is on one of our national flagship digital and data programmes, and it is about creating that platform that enables that federated and collaborative way of working. It will underpin the single record, the operationalised use of our data, and it will facilitate the use of AI in our operational practice. It will also deliver our national analytics platform so that we can start to really maximise the opportunity that the data provides for us, and also support our partners across academia. So for me, just to set up, I think harnessing data is essential to delivering a healthier Wales. You can't do one without the other, in my view, by aligning strategy, technology, and indeed culture. And I know Dr. Michael West is going to be speaking shortly around compassionate leadership, and actually people, whether that's patients, whether that's our staff, are at the heart of everything we do. So I think in Wales, we will build that transformative, data-driven health system that can indeed improve lives. Thank you very much, and hopefully you'll have a good couple of days.
So a dear friend and also a keynote speaker this afternoon, Steve McFeely, currently in the role of Chief Statistician of OECD, asked me yesterday at the dinner, why Wales? And I told him, I hope that by the end of these 2 days, you will discover why Wales. Let us now listen to the keynote, remote keynote from my also dear colleague, Dr. Michael West. Unfortunately, he cannot be here, but we get a sample of his presentation, and I hope you enjoy it.
Bore da pawb, my name is Michael West. I'm Senior Visiting Fellow at the King's Fund and Professor of Organisational Psychology at Lancaster University, and I have the huge privilege of working with Health Education and Improvement Wales to develop more compassionate cultures across health and social care across Wales. I think our approach to how we manage our healthcare systems must be an approach founded on evidence and data, and I want to share some of that data with you this morning. So we know from many studies in healthcare what are the cultural elements that are associated with high quality care. The first is that high performing healthcare organizations have a really clear vision and set of values which guides their decision making day to day. But we've also drawn on the data, the best source of data we have available, to help us define the contents or the approaches in our organisations to deliver high quality care for the people of Wales. I led the design of the English National Staff Survey for the NHS back in 2003. And that survey has run every year for the last 20 odd years. It's the biggest, longest running staff survey in any sector anywhere in the world, with over 650,000 people responding every year. And what it tells us is the single most important predictor of the performance of healthcare organisations 2 or 3 years down the line is the level of staff engagement. What the data also tell us are what are the organisational factors which make a really positive difference to staff engagement. We know that compassionate and supportive line management or leadership is the single most important determinant of staff engagement, along with other factors like flatter hierarchies, appreciative cultures where people feel valued, respected and supported and empowered, and particularly working in well-structured teams. And so when we think about cultures of equity and inclusion, this is not just a moral and political imperative, it's also a hugely important imperative for patient satisfaction, which, as we know, is a really important determinant of healthcare outcome. What's also remarkable from the data is just how important the quality of team working is in healthcare organisations to the outcomes we seek. So the more people who work in teams with clear goals and that meet regularly to review their performance, the better are the outcomes on a whole range of parameters, as you can see here. 50% lower staff stress levels, less violence against staff, much more innovation, but people innovate within safe protocols, higher levels of patient satisfaction and significantly lower levels of avoidable patient deaths, along with better care quality generally and better use of financial resources. So the priorities are for us, I think, to directly address the workforce crisis that we face in health and social care, and particularly to ensure that we are making compassionate leadership the heart of our strategy for reasons I'll explain in a moment. And we also need to address this issue of staff stress that we're facing, with 30% of staff in the Wales staff survey and the English staff survey reporting being burned out at work, either often or all of the time. Compassion has to be at the heart of our approaches, because compassion is the core value of staff. What we've seen over the last 40 years of our research is that virtually all staff, 99.9%, have a core value of compassion, of wanting to provide high quality, continually improving and compassionate care for those they serve. And it has, if you like, three directions: the compassion we show to the people we serve, the compassion, how good are we at receiving compassion from others, and the extent to which we're able to show compassion to ourselves. That in turn enables us to empathize with the other person, to feel their pain, and that gives us the motivation then to help or serve them in some way. Because we've been hardwired by evolution to be compassionate to others in pain or distress, it's in evolutionary terms fundamentally important to us. We're as likely to die from the effects of loneliness as we are from the effects of smoking 15 cigarettes a day. But we also know, the data tells us, that compassion is the single most important intervention we have available to us in healthcare. And I'll show you briefly some of the many studies actually on compassion, randomized controlled trials and meta-analyses. And as you can see, in that condition, patients have a much lower requirement for painkillers post-surgery, and they have a significantly shorter length of hospital stay. Second example is a very famous large randomized controlled trial of patients with an early diagnosis of lung cancer, randomly assigned either to normal early cancer care or normal early cancer care plus early palliative care. And we see similar large effects of clinician compassion in the treatment of long-term disorders like HIV, diabetes, and of therapist compassion in the treatment of mental health problems. In randomized controlled trials with GPs and nurses briefed to be extra compassionate with patients over a 2-week period, we see that that has a significant impact on their own mental health, with lower levels of anxiety, stress, and depression. Consistent with the neuroscience studies, it shows that when we're compassionate to others, they benefit, but also we benefit. And not surprisingly, the data show us there are huge financial and organizational benefits from compassion. Suffice to say that compassion is the single most important intervention we have available to us in healthcare. So the challenge is, for us as leaders, how do we create the conditions in our organizations where staff will be even more compassionate to those they provide care for, even more compassionate to each other, and even more self-compassionate? Well, every interaction by every one of us every day in our organizations shapes the culture through how irritable, passionate, cynical, kind, humorous we are. But we know from the last 100 years of research on organizational culture internationally that the role of leaders is particularly powerful, because what leaders pay attention to and talk about and what they model in their behavior tells us what it is they value. So if we're to create even more compassionate cultures in healthcare, then we have to ensure our leaders model compassionate leadership. The most important skill of a leader is listening to those we lead. And the most important task of a leader is helping those we lead to do their jobs more effectively by helping to ensure they've got the resources, helping to remove obstacles. On the contrary, it requires much more courage and authenticity than command and control leadership, because compassion is about leaning into pain and difficulty. Compassionate leadership is about addressing difficult and toxic behaviors in our organizations, not ignoring them and hoping that people will leave. It's about having the courage to lean in with compassion, to give negative feedback to people when required, not simply creating appreciative environments. It's about having the courage to deal with conflict in compassionate ways, because conflict helps us resolve some of the challenges of trying to ensure high levels of productivity at the same time as innovating. We also know, as I've said, that team working is fundamental in our organizations to delivering the outcomes that we seek. We know, by the way, that the most important factor in team effectiveness is that teams have agreed a limited number, 5 or 6, clear, challenging goals. You may think that we're already doing this, but the data we've gathered show that only about 40% of teams in healthcare have clear agreed goals and meet regularly to review their performance. If you could, from the data, find an intervention that would improve productivity by 35 to 40% and wouldn't cost you anything, I'm sure that you would be delighted to grasp it. At the beginning of the 1990s, we started asking a question: what happens if teams take time out on a regular basis to stop working and review what they're trying to achieve and how they're going about it? Our research and other research has shown that teams that take time out for debriefs, after action reviews, away days, for example, are profoundly more innovative and much more productive than teams that don't. Indeed, one meta-analysis showed that teams that took time out on a regular basis were on average between 35 and 40% more productive. Well, the data tell us that most organizations are implementing what we would call tertiary and secondary interventions to deal with staff stress, focused on treating the resulting ill health or helping people be more resilient. Those that are focused on changing the workplace factors that cause staff stress: chronic work overload, poor team working, poor leadership, poor facilities and equipment. I've been involved in co-chairing, leading 2 national inquiries into staff health and well-being, one on behalf of the General Medical Council, one for the Royal College of Nursing Foundation, and we were able to understand from the international data and national data across the UK that the reason that staff are stressed is because we're failing to meet their core human needs for autonomy and control, belonging and contribution. And we were able to distill from the data those 8 areas that we need to address to ensure that we're creating the best working conditions for staff to ensure high levels of intrinsic motivation, innovation, and well-being. And they are ensuring that staff have voice and influence, that they work in cultures of justice and fairness rather than fear and blame. The work in an Iron Bevan health board in South Wales, a very good example, giving staff good working conditions and influence over work schedules and rotas, building team working, creating cultures of compassion through developing compassionate leadership. And it's about addressing this issue of chronic work overload. East London Foundation Trust, in a very challenged area of London, in the context of its amazing quality improvement culture, regularly asks its staff what they would reduce or get rid of in their work. They've eliminated 85% of clinical audit activities. They're rated outstanding by CQC. We have many examples of organisations that are addressing these issues and getting these things right across Wales and the rest of the United Kingdom. We can do this, but we have to be courageous and show wisdom to make the changes. So these are the key themes I think we need to address to create psychological safety and safeness in our organisations, and the condition where staff will have high well-being and high levels of trust, and where they'll deliver the effectiveness and innovation we need in order to meet the health and care needs of the people of Wales. But I began by emphasising the importance of self-compassion, and we now know from the data that in order to be truly compassionate to others, whether you're a leader or a healthcare provider, that it's vital that you practice self-compassion, that we know that self-compassion is simply giving the same kindness to ourselves that we would give to others. And when we engage authentically, courageously, and compassionately with ourselves, the data show us that that enables us to engage more authentically, compassionately, and courageously with all of those we provide care for, all of those we lead, indeed all of those we interact with in our lives. So for everybody here, all of this begins with having the courage to be self-compassionate. So diolch yn fawr pawb, thank you very much for the privilege of sharing this with you today. Enjoy the conference.
Thank you so much. I hope that this video keynote by Dr. Michael West starts shedding some light on why Wales. And I was very pleased to see Helen just sitting by me and nodding constantly to the good wisdom that was shared by Dr. Michael West.
Everybody is looking for better healthcare solutions. What if AI could be the answer? AI in healthcare isn't just a buzzword, it's revolutionizing patient care. With AI, we can achieve more accurate diagnoses and personalized treatments tailored specifically to each patient. AI systems analyze vast amounts of medical data at lightning speed, identifying patterns that might be missed by human eyes. This means early detection of diseases, fewer errors, and more effective treatments. But the magic doesn't stop there. AI helps streamline administrative tasks, giving healthcare professionals more time to focus on what they do best, caring for patients. The result? Enhanced patient outcomes and improved quality of life. So whether it's predicting patient needs or making real-time decisions, AI is transforming healthcare, one patient at a time. Embrace the future with AI-driven healthcare solutions. Because better health outcomes start with better technology. Ready to take the leap? AI in healthcare, better diagnoses and treatments, making healthcare smarter, one innovation at a time.
With pleasure that we have here Ifan Evans, joined DHCW in 2022 as Executive Director of Strategy. His responsibilities include strategic planning and organizational performance, digital transformation programs, commercial services, engagement, and partnering. Ifan began his career in the private sector, leading several small businesses in retail, hospitality, and property sectors. He moved to the public sector in 2007 as a director at the Welsh Language Board, leading on private sector and business engagement. He then joined the Welsh Government as lead for life sciences and health in the economy department. He later moved to the Welsh Government's health department, where he wrote the strategy for health and care, Healthier Wales, and built a new directorate focused on transformation, innovation, and digital. He was the national lead for Brexit readiness across health and care and for the digital response to the COVID-19 pandemic. Ifan has been a champion across government and NHS for digital transformation technology adoption and innovation. He's passionate about data as tools to clarify and simplify, reducing unwanted variation and making service better for professionals and the public. Thank you so much, Ifan, for joining, and the floor is all yours.
I'm really not sure you should clap before I've started. You should hang on for a while. So there's been a bit of an information overload, so I've got a lighter set of slides. I was worried that we might not be on time, but we are bang on time, so I've got the full 15 minutes. But I'm going to try and share a couple of stories and some metaphors. And the reason for that is that I'm practicing, so I'd really welcome any sort of feedback in the break afterwards. I'm working on the assumption you guys are all fans of data, you all understand data. But most of the time I'm talking to audiences that are not as technically literate, that are not as into the data. And a big challenge for us, an opportunity as well, is to try to help them to understand what it is that we're doing, the importance of data, and how data translates into action in healthcare systems. So I'm trying to use and trying to explore ideas of systems that explain why that works. So I'm just going to start. This is the stuff that you know, I guess. So data just doesn't do something on its own. You need to translate data into information, use that information to make decisions. The decisions, actions need to follow from those decisions, and then hopefully you get improved outcomes. But the key thing is everything starts with the data, and it only makes a difference if it's used by somebody. If you've got data locked away in a filing cabinet and nobody looks at it, then it doesn't do anything, does it? I mean, you can collect as much as you like, but if nobody's using it, it doesn't actually do anything. And this is a quote that pops up quite often. If you can't see the slides behind me, I'll just get back here. The NHS is kind of data rich and information poor. So data, there's lots of paper. When we were doing the Brexit readiness, this is an opportunistic story. When we were doing the Brexit readiness, by accident, probably the cleverest thing that I did was to buy a gigantic warehouse. It was completely accidental. But it turned out to be a great decision in retrospect. And the first thing that we did with that warehouse was we turned it into the attic for the NHS. So all of the documents, all of the archive stores that were scattered about NHS Wales, we moved them all into this huge 500,000 square foot warehouse in one place. That's what we do at home, isn't it, right? We move all of our files into the attic. And that cleared up space that was much more useful in other places. That data was pretty useful useless, really, right? It's just pages, pages, and pages of stuff in archive boxes that nobody can read, nobody can analyze, nobody can use. So that data goes back many, many, many decades. Digital can really help us to do that. It turns the whole stuff into things that we can transact, we can use it, and we can use it across the whole system. You can't easily share an archive box to North Wales, South Wales, West Wales. But if it's digital, then you can, obviously. But we still collect data on paper. We're not paperless in any way. And the way that we collect and store digital data is inconsistent across the system as well. And sharing data is how we try to approach this. So the data is locked up in lots of different systems. We try to share between those systems. That tackles the fragmentation of data across a digital estate. Unfortunately, it also creates duplication and variation. So you take a copy of the data from system A into system B, and it loses the persistent connection. It starts to evolve differently in B. So before long, you find that you've got duplication, you've got variation, you've got a different sort of set here compared to what you've got there, and then you copy B into C and C into D, and you've got the same data scattered around. So yes, it deals with fragmentation, but it drives duplication. And the NDR, which is what I'm going to talk about mainly, is a better way. I've got a caveat. So how many doctors do we have in the room? Always very dangerous. Only 3, what a relief. So this is not a criticism of doctors, this is a story about human nature. Who's heard of Ignaz Semmelweis? Ignaz Semmelweis? Yes. 2, wonderful, right? Ignaz Semmelweis is a Hungarian doctor. He notices that lots of women are dying, and they tend to die disproportionately if doctors are treating them immediately after treating cadavers. This is in the 1840s, in his 20s. So he collects some data. Sensible guy, right? Sensible guy. He collects some data, and the data shows that if you wash your hands with chlorine, then fewer women die. Pretty straightforward. The information he derives from that is you've got to wash your hands. Washing hands is really important. He thinks there's cadaverous particles that are moving. That's the word they use, is cadaverous particles. However, he's in his 20s, so he starts telling other doctors, and he's Hungarian, so he starts telling other doctors, and they say, nah, don't think so. Don't think so. No, I don't believe you. And he goes, here's the data. Here's the information. It's incontrovertible, right? I've demonstrated this. Within 5 years or so, he's in a mental asylum, and he kills himself at 47 years old. And then somebody else turns up, Louis Pasteur turns up. It's like, oh, he was right. And now he's the father of hand washing. So data turns into information, does not necessarily turn into decisions, is number one. And that is, I think, really challenging for us, because even now, every autumn, there's a campaign in all health systems reminding people to wash their hands. This is like 150 years afterwards. So it is not the evidence-based system that we think. It is not as rational as we think. But we still need to do what we need to do, which is the data and the information, because without the data, then you couldn't do anything, right? So he was right. It took a long time, but it's still better that he was right, and it is still better that the data was there. So I just want to condition this. This flow is really important, but it all starts with data. So this is our architecture for the National Data Resource. This is where I'd really welcome some feedback in the break afterwards, because we're trying to come up with a way of describing how this is different in small ways, but in important ways, to the way that data sharing architectures usually work. So current best bet is shared data, it's a shared data architecture, not a data sharing architecture. So I'm trying to think of something which is a bit punchier. If you can help me, then please do. What this is the National Data Resource. It's a single source of truth record. These are all the systems, so we all have these in all of our health systems across the world. This is how it works. The difference is that these are not sharing data with each other. They're reading and writing only to the National Data Resource. And if you look at the color blue, right, the dark blue means Fast Healthcare Interoperability Resources, R4. Right, so that is FHIR R4. They are only allowed to speak to the National Data Resource in FHIR R4. This is not our current architecture. So our current architecture is all the applications in different colors here, in blues and greens and yellows and everything else. They all speak directly to each other, and they speak to all of each other. As I said, I'm constantly trying to think of ways to illustrate that. So at home, I speak Welsh. Bore da. Does anybody speak any language other than English at home? 1, 2, 3, 4, 5, 6, 7, right? And the rest of you speak English at home, right? That's 8 languages. Let's imagine we wanted to get our homes to talk to each other. and we all want it to talk to each other. I don't know, how many translators is that, all right? Let's imagine also there are 8 different languages. That's an n+1 problem. Because I've got to speak 8 languages, you've got to speak 8 languages, and there's various sort of combinations of those languages. That's pretty difficult. That's pretty complicated. We need a lot of translators to do that. That's what our architecture is at the minute. Right? That is how we do health architecture. Every system speaks its own language. It rocks up, a supplier turns up with their spec, and then it has to integrate to all the other systems with their specs. And we create complicated architectures in between that do the mapping, the translating, and everything else. That's really, really difficult. It's not what we're doing today, is it? Right? We're all speaking English. I'll go home tonight and I'll speak Welsh. Well, I'll kind of slur maybe after the dinner, right? But I'll go home and I'll speak Welsh. You go home and speak your language in your home. But when we're here in the conference, we're all speaking English. So I've only got to handle one translation. I only need 2 languages. That's much, much simpler, isn't it? But that's not where we are at the minute. But that's where we want to get to in Wales. So I'll try to turn that into words. And the first sentence is the one that I want to focus on mostly, really. Because I misunderstood this, 2 or 3 years ago. I joined DHCW, and I should have known better. I'd been in government. I was funding the National Data Resource. It's a major programme, a 10-year programme that has come out of a Healthier Wales, the strategy. And I had in my head that the National Data Resource would become the data layer for the applications that we use. We'd substitute the proprietary data layer or data store in each application with the NDR, and that would give us one data layer. Sounds lovely and neat. That's not what the NDR is, right? So every application still holds its own data. I'm going to go through the data sharing first, which is what we currently do. I'm going to lose the microphone. So every application holds its own data. Applications share data to other applications in various formats. This is how we currently do it. An integrations engine will synchronize all of that data. We've got a flow, we've got orchestration, we've got brokered messaging, we've got audit logging and various other things. And when you want to share care records, you fetch and gather from all of those systems, you bring it all together into one place to give a consolidated view of the single record for that patient. That needs a lot of complex business logic, because the same information is held in all those different systems in different ways and in different sort of combinations. You've got to reconcile that, you've got to link it, because they're using different patient identifiers. You've got to map the translations, you've got to handle conflicts, you've got to resolve ambiguity in that data. It's really hard to make those decisions centrally in your programming messages because you don't know the context in which that information was captured or what it really means. Only the system knows what it really means that you're collecting it from. Any new application needs really complex integration to that estate, and that's an N+1 problem. If you've got 100 systems already and you've got one more, and you want them all to talk to each other, you've got to make 101 connections. You've got to get 100 connections, sorry. But it's a lot, right? And then the next one, you've got to make 101 new connections, and it just gets worse and worse and worse. There are really strong dependencies between the applications because the information is held, so each application is kind of depending on the other. And when an application is retired, and I've used retired as a sort of general catch-all, they take their data with them. And they might be retired because they're being hacked by cyber actors. So you turn them off, you take them off your network, the data's gone. They might be retired because they're into administration, like our primary care provider for half of Wales went into administration before Christmas. And for a short time, there was a real risk. That system would just drop off the network, and it would take all of its data with it. Half the primary care data for Wales would go and would not be visible through our clinical portal, just like this. I mean, that's not very good, is it? That's not very resilient. So the shared data architecture is similar but different, and it's different in small.
Sorry, because
Oh, I'm so sorry. I hadn't realised they were online. So I'm back on the mic now. So in the shared data, every application still holds its own data, but it only writes to one other application. It writes to the National Data Resource, and it uses Fire to do that. You can use Fire, or you can forget about it. You're going to use Fire. And it's the application's job to do its own internal translation to Fire. It controls it. We don't compensate for the deficiencies of the systems. We require the applications to do that. Every application then reads from the NDR. It treats it as a source of truth, but it gets the whole picture because every other application is also writing to the NDR. So they all write and they all read, and that means that they can all see the whole picture at any time. They don't exchange data with each other. That's talking in dark corners. That's secret swirl conversations. If they do that, then no other applications knows what they're doing. And what they're doing is clinically relevant. Clinicians need to know, and analysts need to know. the NDR persists the data as well, right? It holds on to it. And that means that the NDR itself can act as a shared care record. An integrations engine, complex business logic, is optional. You don't actually have to have that. You can get away with the simplicity of up and down, although you might still well choose, and probably would, to have an integrations engine. New applications only need 2 connections. I mean, conceptually they need 2. Obviously there'll be lots of different APIs, lots of different domains, lots of different file profiles, but they only need to connect to read and connect to write to the NDR. They don't need 100 connections. Your 101st system doesn't need any more connections than your first system. It's radically simpler and therefore easier to control, and it stays simple. There are no dependencies between the applications because they don't know about the other applications. They don't know how many are connected. And if an application retires, then it leaves quietly without taking its data with it, because the data has all been written, the relevant data has all been written into the NDR. That's the ambition. It's really, really difficult to achieve that, but not impossible. Who uses email? IMAP works like this, right? IMAP works exactly like this. There is one IMAP store. I've got 5 devices, 4 or 5 devices connected to my IMAP email store. I can change emails, I can send emails, I can write emails. In every single one of those devices, it'll update the IMAP store, and it'll be the same across every device. No device knows anything about any other device. No device even knows that there are other devices. I've got stuff in my IMAP store, emails that go back to 2010. The devices and the software that I use don't even exist anymore, but the email is still there. Now, I know email is really simple, right, because it's an extremely one-dimensional sort of standard, and health is vastly more complicated. But in digital, you can create very complicated things out of very simple things. One of the best books I've read about IT is a book called Code, and it sort of walks you through how one switch is what creates artificial intelligence. One relay creates your logic gates, creates your CPUs, creates your processing, creates your memory, creates everything else. It's a fascinating, fascinating book. Just because it's simple doesn't mean it can't be very clever, and it can't be sophisticated, and all the rest of it. So that's where we currently are in terms of trying to describe the difference between what we're currently doing and what most systems are doing, and where we want to get to, a shared data architecture instead of a data sharing architecture. So getting there is going to be really, really, really hard. This is our shared data architecture. Right? Everything is all mixed up. It's all over the place. I mean, it's still tasty and nutritious, right? It still maintains healthcare services. In Wales, we've got 40,000 users today using a clinical portal. They can see all the images, all the lab scans, all the results, all the nursing forms. They can even look into the GP record. So, that's pretty impressive, but it's all like this. And every time we add anything to it or take anything away, that's really, really hard, because it's hard to understand. And we want to get to this. Nice and clean and managed and vertical, up, down, read, up and write down. So getting there is going to be really, really hard, but it's worth it, because if you haven't got good data, then you cannot provide good health and care. Now, some of you are of a certain age, and you might remember this advert. Look at him. Oh, isn't he beautiful? All right. A dog is for life, not just for Christmas. Do you remember it? All right. 1978. That's when they ran that advert. I was 5 years old, and I can still remember it. I can still remember it. This poor little dog. Right? My TV would probably have been about A5 size, right? In my memory, it's like this, right? But stories and words are really, really punchy. So I've been using this quite a lot. Data is for life, not just for Christmas. And if it's for life, it cannot rely on any one application that we use, or any technology that we use, or any system that we use, or any vendor that we use. We can't afford to be locked in, because we're still going to need it in 50 years. And by then, we won't be using the software that we're using today. We won't be using the vendors that we're using today. We won't be using the devices that we're using today, but the data is still there. So data is more important than anything. And I know this is a helpful, friendly audience about everybody loving data. Hopefully that was diverting. And hopefully it's helped you to understand the difference between what we're trying to achieve and what we've got at the minute. If it hasn't, and you've got any ideas about how we can improve, as I said, right, the most important thing for me is to help non-technical audiences to understand what we're trying to achieve with the National Data Resource and why that is so important. So I'd really be very grateful for any sort of improvements or suggestions. Diolch yn fawr iawn.
Welcome to the future of health innovation. Are you an innovator at the cutting edge of social impact and health technology? Then get ready to discover a unique opportunity. We are thrilled to introduce the Social Tech and Health Innovation Village, a dedicated space designed for visionaries like you. This exclusive showcase is a key highlight of the Health Data Forum Global Summit 2025. So what exactly is the Social Tech and Health Innovation Village? It's a unique showcase area specifically curated for innovative companies, dynamic startups, and groundbreaking projects. This village is where social impact seamlessly intersects with health technology, fostering collaboration and progress. Curious if the Innovation Village is for you? We're calling all social tech startups, health AI, and data innovators, and real-world evidence enablers. Also, patient empowerment platforms and care pathway disruptors are highly encouraged to participate. And of course, digital inclusion pioneers who are bridging the tech gap in healthcare. Why should your innovative project be part of this village? Gain unparalleled visibility among influential healthcare leaders, policymakers, and fellow innovators. Enjoy direct networking opportunities with summit speakers and key sponsors, fostering invaluable connections. Your company will be prominently featured on the summit website with your logo and project bio, boosting your online presence. You might be wondering, where exactly can you find this exciting hub of innovation? The Social Tech and Health Innovation Village is strategically located in the President's Room, right in the coffee break corridor. You'll also find a presence in the main lunchroom, ensuring maximum foot traffic and engagement. Plus, your presence will be highlighted on both the official event website and the printed agenda. Don't miss this incredible opportunity to amplify your impact. Join the Social Tech and Health Innovation Village today.
Venture into the frontiers of healthcare data innovation with the Health Data Forum. Welcome to the Health Data Forum's YouTube channel, your gateway to thought-provoking conversations, cutting-edge insights, and groundbreaking advancements in healthcare data. Join us as we explore the transformative power of data to revolutionize healthcare delivery, patient care, and societal well-being. Embark on a journey of discovery. Delve into healthcare data through our informative videos, featuring leading experts, thought leaders, and innovators. Discover how our global movement, Data First, AI Later, is building a strong foundation for ethical and impactful healthcare solutions. Experience the collaborative spirit. Be a part of our vibrant community of health data enthusiasts, where ideas converge, partnerships flourish, and innovation takes center stage. Participate in discussions, share your perspectives, and join us in shaping the future of data-driven healthcare. Stay informed about the latest developments in healthcare data through our comprehensive video library. Catch up on insightful interviews, thought-provoking presentations, and engaging discussions about the role of data as the backbone of healthcare transformation. Join us in shaping the future of healthcare. Let's harness the power of data to transform healthcare for the better. Subscribe to our channel today and become part of the Health Data Forum's mission and our Data First, AI Later initiative to make healthcare data work for everyone.